Dear Chairman, dear colleagues, it's an honor for me to be invited by Dr. Chang to the OACT conference affiliated with the Korean Society of International Cardiology. I would like to apologize not to be able to be live, and so we record this presentation. So my title is Non-Invasive Transthoracic Shockwave Therapy for Calcific Aortic Stenosis. Here my conflict of interest, and as you know, there is still an unmet medical need in aortic stenosis. For example, 500,000 valve replacement per year worldwide, and we have 1.5 million patients with severe aortic stenosis still not treated. It's also known that 16% of severe symptomatic aortic stenosis patients are denied access to valve replacement for frailty or severe comorbidities. And in a limited number of cases, extreme leaflet calcification, especially in case of bicuspid aortic valve, might still offer unsurmountable obstacle to optimal TAVI treatment. And last, in moderate aortic stenosis, we know that subgroups of moderate aortic stenosis are at high cardiovascular risk, and perhaps they can benefit from TAVI. Moreover, 74% of 2,420 PCI centers in Europe don't perform TAVR, and 51% of European population live in a region with PCI-only centers. So we think that we can find for less invasive or non-invasive solution, prosthetic-free, minimal procedural risks, delay or avoid aortic valve replacement, and a procedure with lower morbidity and mortality risk with this old and comorbid population of aortic stenosis. We set up a startup company, spin-off of our university since 2015, called Shockwave, and we are quite happy to have an honor to have Professor Alain Cribiez that really believe on this new technology from the beginning, with Professor Robert Levin from Boston and Professor Ehud Shomental from Israel, and Professor Roxana Mera that we know that will be here during this session. The idea is to propose a completely prosthetic-free concept of calcium fibrillation for improving leaflet mobility and increase valve opening. We developed for this a new therapeutic device called ValvoSoft. The procedure will last only 70 minutes with 7 sessions of 10 minutes. No need of CAD lab, easy to use, fast learning curve, safe for the operator, no radiation, and as we say, completely non-invasive. This non-invasive ultrasound therapy uses focus, very high frequency and short ultrasound pulses that create microscopic cavitation bubbles. When cavitation bubbles burst, they produce shock waves. Shock waves cause microcracks in valve calcification without tissue damage. And the goal is to soften the valve, restore leaflet mobility, and enables a wider opening of the valve. Here an example where we can find the bubble cavitation that is created by this high power ultrasound and high frequency ultrasound, either in the anterior right cusp, anterior left cup, or posterior cup. This is the in vitro study. We first published the proof of principle of this new concept and new technology in 2017, and using in vitro model and in vivo model using a very calcified bioprosthetic valve harvest from patients that undergo cardiac surgery, we were able to demonstrate a decrease thanks to this cavitation of 50% of the mean aortic valve gradient and an increase of the same amount of the AVA. In the second stage, we did an in vivo model by implanting this calcified severe bioprosthetic stenosis valve into the mitral position of a sheep heart, and we sent this in open heart, and we were able to also demonstrate a decrease of the mean gradient by 50%, increase of the AVA, of the mitral AVA, by 50%, and without any discrepancy in terms of cardiac output, heart rate, or blood pressure between the two stages. We correlate this improvement by the softening of the leaflet evaluated by elastography. Histology find out that we create micro cracks into the calcium of the valve without damaging the valvular tissue. We also did transthoracic PORC study on normal valve to demonstrate our ability to focus the ultrasound transthoracically without any side effect, no acute stroke, no heart failure, no aortic regurgitation. And thanks to that, we get the authorization from the regulatory body in France and in Netherlands to do the first in-human study that we published in Circulation in 2021 on 10 patients with very severe aortic stenosis contraindicated to TAVR or SAVR. After we had 30 patients, and a total of 40 patients were performed in this first in-human study, 19 in Netherlands in Amphia Hospital, 11 patients in our institution, and 10 patients in Serbia. The goal was to evaluate the safety and feasibility of this new technology, and the objectives were primary safety endpoint, procedure-related mortality at 1 month, and a secondary primary performance endpoint, improvement in pressure gradient and aortic valve area. Here a demonstration of how the procedure was performed. As you see, it is in at the beginning we start in a hybrid room, and after in a classic ambulatory operating room, even in cath lab, and you choose the zone of interest, and you send the ultrasound by session of 10 minutes, and as you see, the focal point is moving in depth and laterally to scan all the plan of the calcific aortic valve stenosis.
몇 세션 하는 거예요? 우리끼리 막 떠들어도 되겠네요. 궁금한 거 우리끼리 떠들어보자. 10분짜리 세션을 몇 번 하나 봅니다. 네. 10분씩 나눠가지고 몇 번 하는 것 같아요. 5-6번.
Published in Circulation 2021 was a decrease of the mean gradient by 23.5% and an increase of the AVA by 27%. And we also demonstrate the absence of silent CVA as asked by the FDA. So 10 patients performed in Belgrade get systematic cerebral MRI before and after the procedure, and we didn't find any silent CVA or obviously any clinical CVA before and after the procedure, and even after 1 month follow-up. We are quite happy to get our study published in the Lancet in December 2023 with a very nice editorial. This was our first in-human study on 40 patients with the 6-month follow-up, And the population was quite old, with 83 years old. The left ventricular ejection fraction was quite preserved, with about 50%. The AVA were quite low, with 0.57 centimeters square, and more than 60% of the population has very severe aortic valve stenosis. The mean gradient was only 41 because almost 40%, more than 40% has low flow, low gradient, and 75% of the population are class 3 and 4. What we find, an increase of AVA at 6 months, about 10%, and a decrease of the mean pressure gradient by 7%, compared to the natural history that we know in very severe aortic stenosis, there is a decrease of 0.1 centimeter square of AVA per year, and an increase of the mean gradient by 7 millimeter of square. So we are quite happy to have not only not an increase of mean gradient and decrease of AVA, but an increase of AVA after 6 months. KCCQ was also significantly improved after 6 months, and at 12 months we still find an improvement in terms of AVA and mean gradient. The Kaplan-Meier survival analysis was 72% at 6 months and 57% at 12 months, quite comparable to the partner B arms, where the medical treatment was performed. Thanks to this study, we performed a second study, let's say CE marking pivotal study in Europe, still in France, Netherlands, and Germany, on 60 patients. Again, patients with very severe symptomatic aortic, calcified aortic stenosis, and subjects were or contraindicated to TAVR or SAVR or not recommended by the local heart team. And in Germany and Netherlands, they agree also to include patients that refuse TAVR and SAVR. Main exclusion criteria: we exclude patients with below ejection fraction below 30% or AVA index below 0.24 centimeters square per meter square. We just finished the follow-up in July 2024. We use a new version of our prototype Valrosoft with a biplan guiding echo incorporated into the machine that allow us to better visualize the bubble cavitation and better precise to do the treatment most focusedly on the calcification and more precisely. This is an example of our technology. Here it's an ambulatory operating room in Hôpital Pompidou. You see the patient is only light sedated. You have the anesthesiologist. We can see in the echo light the bubble into the green zone of interest of therapy, with the focal point moving left and laterally, and you can do this during 10 minutes and also move the transducer if you want to target another region. The 65% of femoral ejection fraction of 55%, the AVA was 0.65, the mean gradient was 36, very high calcification score, more than 3,000, and again, very symptomatic and very frail. First primary endpoint, all the patients were alive post-procedure, no CVA, no MI, no serious adverse event. And we can see also the same for the 41st patient. Mean procedure time was 60 minutes. During procedure, pain in 7 patients and 3 mild arrhythmia. Primary safety endpoint was successfully met, but aortic valve calcium load did not change because we don't want to decalcify the valve, but we want to soften the valve. Follow-up, we get a 12% significant increase in mean aortic valve area at 1 month, and about the same at 6 months. And as we know in some publications, that only a decrease by 0.1 centimeter square is associated with an increase of all of cause of death or aortic valve replacement surgery by 16%. So to improve by 0.1 or even less could have an impact in terms of symptoma and prognosis. We get also significant decrease by 14% of Vmax and the same at 6 months. And the KCCQ was also improved at 1 month at 6 months with a 70.8% increase of KCCQ. The 6-minute walk test also improved by 11% in 30 days and by 5% in 6-month follow-up. NYHA, 86% of patients have either the NYHA class improve or stabilize at 1 month follow-up compared to baseline. And 80% of patients have their NYHA class improve or stabilize at 6 months compared to baseline. Survival pivotal study, again, the same, about 70% at 6 months, comparable to the partner B medical arm. So in conclusion, this pivotal study result at 6 month follow-up confirm the initial result from the first human study, improve of quality of life, improve NYHA, hemodynamic change sustained up to 6 months, treatment is completely safe, is feasible in low control environment, short of stay median it was 1 day, and now if we sum up this first in human and the pivotal study, we perform already 100 patients in 12 centers, 4 countries in Europe, with a maximum follow-up of 24 months. We now are working to we submit already for the CE mark approval. We hope to get this first semester of 2025. We apply also for the breakthrough technology in US, and we can expect to have in potential, obviously, and let's say that each center are going to do 20 patients per year, patient per year, and per center, we can expect at the end of the day a possibility of 100,000 procedures per year. Now we target, because of obvious necessity of asked by the regulatory agency, to only target compassionate patients with very severe aortic stenosis, not recommended for TAVR and SAVR, but now we want to focus on more easy for us to treat patients. First, moderate aortic stenosis. As you know, there are now more than three ongoing trials with TAVI and moderate aortic stenosis, and the bicuspid aortic valve, because we know that the result of TAVR is not as good as the one with tricuspid valve, and also there is a problematic of age, and if we can delay a little bit this, it will be great. I did not put this here, but we have also an idea to design a study to improve the TAVR result and decrease the TAVR complication with during the follow-up. So moderate aortic stenosis, we know that it's a huge population, but still have a 5-year mortality rate of 56%, and we know that there are ongoing trials with TAVR, with PROGRESS trial, EXPAND TAVR 3, TAVI and LOAD, and some medication are also ongoing. Our center, for example, are testing pelacarsen in patients with mild to moderate aortic stenosis and LP small a above 70 mg per deciliter. So our idea, and we were quite happy because we got funding from the French government to perform a randomized trial on moderate aortic stenosis trial, about 200 patients. We're going to randomize patients either with sham therapy or with Valvosoft, and with 18 months or 2 years follow-up with endpoint the AVA progression and the Vmax, and also the calcium score. We hope to start this end of 2025. So, to conclude, we think that this Valvosoft therapy, this non-invasive ultrasound therapy, can be complementary to TAVR in some cases, in clinical cases or in technical cases, and should be perhaps presented to the patient by the heart team during the long follow-up of this patient from their mild to moderate status to the end stage where they cannot get any TAVR or SAVR. And in this way, with the possibility of medication or early TAVR, we can take care of our patient by the heart team and the heart centers from their stage of mild to severe, very severe, or contraindicated to TAVR and SAVR, and we can offer to them multiple modality, with obviously the most important will be TAVR, but can be complemented either by medication or perhaps also by ultrasound therapy. Thank you for your attention.
예. 네, 저희 교실에서 했던 그 9번째 윈터 코렉트 심포지엄 파이널 세션에 이렇게 참여해 주셔서 감사합니다. 이것으로 마치겠습니다. 고맙습니다.